Welcome back to the Amid the Mess podcast, where we discuss all types of health and well-being topics, but I really try to make them relevant and possible for people with children. Because let's face it, life is just a little bit more complicated when you also have little ones to look after. Well, today I spoke with Evan Nadler, who is a paediatric surgeon who has spent the last 20 years treating children with obesity. He is now a passionate patient advocate trying to dispel the myths about this disease. So Evan and I had a lovely chat about children with obesity. And it's amazing. It really did surprise me, a lot of the things that we chatted about. And I think this will help you possibly change your mind a little bit, change some preconceptions that you might have. I don't know if this is you, but you may have seen an obese child, or a child with obesity. The language is important. Walking to school, maybe, or to secondary school. And you might just think internally, oh, that, how does that happen? Do they eat too much? Or are they just sitting on the sofa all day long? Like, why does this become a thing? Well, Evan goes into this, and it's really important to listen to this, even if this is, especially if this is not really part of your world. If obesity is not something you're struggling with, or even your children are not struggling with, it's a thing that we need to learn about and understand for everyone around us. And of course, if you yourself are struggling with weight issues, and or if your child is, this will be really useful to listen to as well, with some practical steps that will help you to help this. To maybe change that situation. So, without blabbering on, no. A new thing. I want to just share a bit more about my personal life as well. So, just before we get into the conversation, this week is a momentous week for me. So, baby Daisy is now 1. And this week she starts 2 days at nursery. And I am both really excited and terrified about this because, I've spent the last year spending a lot of time with my baby, and we're super attached. So I'm excited to get some proper time to delve back into my businesses, and to spend a bit more time on the podcast, because I've been stealing minutes here and there to do whatever I've done up until this point. And I tell you, it's been a struggle to sometimes get an episode out every week. So I'm really excited for that, but also feeling all the kind of mum guilt, parent guilt of sending my little girl to nursery. But it's a great nursery, and she's going to love it. I'm sure she is. So that was me dealing with my feelings this week, and excited to have some dedicated work time. But without further ado, here is my chat with Evan Nadler. Evan, what is a misconception about childhood obesity?
So childhood obesity, I think, is actually really misunderstood. And to single out one misconception is sort of hard to do because there's so many. But I would say the biggest misconception is that somehow childhood obesity is a failure of the parents or a failure of the child. Neither of those are true. In fact, I don't even use the word failure when I talk about obesity as a disease, because it's biology. And so, you can't really, obviously you can impact how your biology impacts your life and your health, but you don't always have 100% control over everything. So the biggest misconception is that it's some sort of lack of willpower, bad parenting, social it is certainly more common in socially disadvantaged communities or economically disadvantaged communities, but that's not the whole puzzle. The puzzle really is much more about genetics, something called epigenetics, which most people haven't even heard of. And then I have been really pushing this concept of the intergenerational transmission of obesity, because there is risk that parents pass on to their kids that they know about, and then there's part of the risk that they pass on to their kids that they probably don't know about. So that's why I'm out here trying to educate the masses, because it's a really underappreciated and underdiscussed part of the problem.
Absolutely. I think what you just said will have surprised so many people. It's very easy to sit from our kind of position of being a normal weight, and you see someone maybe who's very obese, to think, oh, well, they're obviously doing something wrong with their diet or their exercise. And so that's really interesting.
Yeah.
I mean, I say that I don't want to sound like a judgmental person, but I think I must speak for so many people.
Right.
And I love that you started
me,
off with that one.
Yeah, believe me. So I've been doing this for 20 years, actually more than 20 years now. And especially in the early days, people thought I was, because this is a UK-based podcast, I'll use the word mad. People thought I was mad. And and I was a bit, because that's what takes sometimes to buck the system.
Yeah.
So, but I would tell audience members at medical conferences who couldn't believe what I was trying to tell them, to just come spend a day in my office, and it would completely blow them away. And I sort of say that to the people out there who are listening, or the masses, is if you come to my office and you hear what the kids are doing or eating, you won't hear that they're, eating at McDonald's 5 times a day, or, sitting on a couch playing video games. In fact, the opposite is usually true. They're usually trying really hard to manage their weight, and it's just not working.
Okay, interesting. So, I mean, let's give some definitions. So, in the way that you work, what is childhood obesity? And then how is it different from adult obesity, perhaps?
Right. So the definition of obesity actually is somewhat evolving, and there's a bit of a international discussion over what the diagnosis needs to be made. In the Lancet, which is a UK journal, commissioned a group of experts to discuss that very topic. But no one, you put 50 experts in a room, you get 50 different opinions. So I wouldn't say it was
and opinion isn't always science, or isn't always correct, is it?
That is
expert
true,
opinion.
Right.
Yeah.
So I found that the publication that they put out to be sort of less than useful. But so the way most medical people will define it is based strictly on your weight and your height. So something called the body mass index.
BMI,
and it's really a screening tool, BMI. It's really a screening tool. So it shouldn't necessarily be used to define the disease, but it is, especially in the US and probably in the UK.
And you get a lot of people who are like really muscly. They are actually in the classification of of obese, or people who are quite small but actually have no muscle at all, and actually have intra-abdominal fat, and actually aren't healthy. So it's not a great measure, is it, BMI?
No, and some publication just recently where they used sort of health indicators, metabolic indicators, and not the BMI, found that there are some large number of people who are walking around with a BMI that is not in the obesity range, but actually have significant health problems. So, and it also varies by ethnicity. So, BMI was devised for basically European Caucasian people and not for other ethnicities. So, for instance, in Southeast Asia, they get diabetes at a lower BMI than people in the US would. So for them, the numbers are completely different. So, but for me personally, I define it loosely as if your weight is impacting your mental or physical health, then whether or not you have the disease, quote unquote, of obesity, you have a weight issue, and you deserve some help if you want it. So I don't get too tied into the numbers so much, unless I'm, again, in the US, it's a bit different because we have to fight with the insurance companies to get coverage for different treatments. But so that's when the numbers are important, because you can better advocate for your patient. But in terms of just general health, I mean, again, if your weight is leading to bullying or self-esteem issues, or things that we don't necessarily usually equate with the disease of obesity, it's still equally as important. Like, to me, it doesn't make a difference. It's somewhat of a arbitrary distinction.
Or maybe it's stopping you doing things that you want, like physically making it difficult for you to do stuff that you want to do.
100%. The common stories I would hear in my office would be about kids not being able to get on the roller coaster because the metal arm that would come down couldn't come down safely for some of them.
That's so sad for them.
Right.
Yes,
and so that's the heartbreaking bit of it, is when, again, when you talk to these kids and they tell you what they can't do, and then they start to just avoid it socially because they know that it's going to be an embarrassing moment and they don't want to be there when it happens. It just leads to such social isolation, which just compounds the whole problem.
Oh, yeah, that definitely. Yeah. Wow. Such an important topic and so interesting. So, you talk about the kids that come into your medical office. So let's get into the actual why. So it's, tell us, in your experience, what are the factors? And I'm sure it's multi-dimensional, multifactorial, but let's understand it actually a bit more than they just eat too much and exercise too little.
Sure. So at my core, so I wear many hats, and my number one hat is probably patient advocate. And maybe 2 is expert clinician, or maybe 2A is expert clinician and 2B is scientist. So it's not really, this is not purely clinical experience. It is I actually even had a startup company looking at fat cell biology that unfortunately didn't allow me to quit my day job or do this. That company's gone under. But regardless, but regardless, we had good science, and so the disease of obesity in kids and in adults, but especially in kids, is what I like to call a phenotype, and that is the way something looks on the outside. So obesity to every person in the street looks the same, right? You look at someone across the street, in your head that they have a weight issue, but you don't know why.
Yeah.
And that's the genotype part of it. So genotype is the pathways on the inside that lead to the way something looks on the outside. And childhood obesity comes from multiple different genotypes. For instance, people don't know that if you have a brain tumor that is removed via surgery or treated with radiation, that can cause obesity. The genetic pressures, so there are single gene defects that cause obesity, but those are pretty rare in Western cultures. But there are other genes. There's something called polygenic obesity, where you have multiple different genes that may impact your metabolic pathways, your hunger and your fullness, and all these different things. And so, I sort of try to tell people, when I put on my sort of surgeon clinician hat and I try to keep things simple, I say, if I'm looking at a 11-year-old in my office with type 2 diabetes from their weight, they've only been on the earth for 11 years, and they've only chosen what they've had to eat probably for 6, because up until at least 5, they were just getting whatever their parents, and maybe even later, right? So to sort of think about the environment causing that disease it actually doesn't even make sense if you just look at the time on Earth, right? So people who get weight issues in their 40s, maybe that's different, and maybe that's from decades of poor food quality or whatever, but not in a 12-year-old with type 2 diabetes. That's just not even, again, it just doesn't even make sense. Not to mention who would do that to their child, and what child would choose that, right?
Yes.
Like it goes against all common sense to me, yet it is the most common misconception. But even not like on my YouTube channel, like whenever there's a troll or a hater or whatever, it's just tell the kid to get off the couch and he'll be fine, or just tell him not to eat so much. It's the same thing over and over again, which is why I'm out here trying to say the opposite over and over again. I'm trying to fight the noise with the signal, or whatever you want to say, however you want to call
fantastic. Super. Wow. So you're talking about genetic predispositions to becoming obese, that it doesn't really make sense to think an 11 or 12-year-old has actually done this through his own volition, or the parents haven't controlled the environment well enough. Okay, so...
Yeah. And then the epigenetic piece, which we didn't talk quite as much about, is where the environment does play a role. And I think this is sort of the science that's emerging. And the war on ultra-processed foods that we're starting here in America, which, in Europe, you guys have done a better job in terms of keeping some of the ultra-processed foods out of the food system, although, your obesity rates are catching up to the US, so you're not immune.
Yeah.
But the thought is that some of these ultra-processed foods, or the forever chemicals that are in the plastics, are changing our genes. So they don't change your DNA, but they change how your genes are what we call expressed, or how they're turned into proteins and how they function. So that might be how over the past 50 years there's been such a huge jump in obesity, because obviously your DNA doesn't change in a 50-year time span. That's too short. But epigenetic changes to genes can be passed on from parent to child. So if you're a parent and you are struggling with weight issues and your genes have been modified, then your kid or kids may not only get your genes that predispose to obesity, but they might get your epigenetic modified genes from your sort of behavioral struggles as an adult. So when people sort of ask me, if you had one thing to do that you thought might help curb the obesity epidemic, what would it be? And my answer is always trying to get young adults, both the men and the women, to address their health issues before they conceive, before they start planning a family, because not only will that child grow up or develop as a fetus in in utero environment, in the mom's belly, as you said in your
yes, the bump.
So not only will they grow up in a healthier baby bump, but they will also potentially get fewer epigenetically modified genes from their parents. And then when they're born, they're actually going to be born into a household where a lot of the behavioral changes have already been made.
Yeah.
And so it's really, to me, a vicious cycle. And that's where we need to break the cycle, is really in sort of, and it's a group of people who don't actually generally pay a lot of attention to their health, but it's, young adults in their years of
kind of 20s
children, 20s and 30s.
Yeah.
And it's a segment of the population that just doesn't generally get a lot of health care. So that would be where I would focus my attention, is on that group, because, the older folks like me, we're thinking about longevity. We're like, okay, we got to get healthy because we want to be on the earth forever. But my kids are grown up now. So whatever health changes I make now don't help them.
Okay.
So anyway,
that's a really good point. So from everything you've said, it's so multifactorial. So food does play a role, and it's mostly kind of the upsurge of ultra processed foods. that, and it's not just the calories that are giving us. People think, oh, it's just because they're super high in calories, but it's the fact that they're changing how our bodies are working, and we can
Right.
pass on those changes to our children, which is why you'd get overweight parents who will have overweight children. And you can assume from the outside, oh, it's just because of the culture within the household. But then that also does play a part a little bit in what you said, because if you sort out the food culture before you have a child, then that child will get brought up in a place where you've kind of
Right.
got to
And
grips
again,
with. Yeah.
yeah, I mean, food culture is important in lots of different cultures. And I'm not saying that people need to, have the strictest of diets for their entire lives. But I'm just sort of saying, child dietary behaviors is formed early.
Yeah.
Usually ages 6
Yeah.
to 12 is what people talk about.
Mm.
So it would help to have some behavior changes, or just, again, structure, right? Like, we're only going to eat out as a family once a week on the weekends and celebrate on Sundays after a hard week of work or whatever,
Yes.
as
Yes.
opposed to, just not paying any attention to it. And especially for kids, like, we know that there are children who will be at higher risk of developing obesity. And those children are the ones who would need the sort of most structure
Yeah.
growing up.
Mm.
But, there's just so many, it is multifactorial. And the most important thing is for people not to blame themselves
Yeah.
or for other people to blame them, because it's not, again, no one
Yeah.
chooses to do this.
It's not sloth or greed or like all these
Right.
silly
Right.
moral judgments.
Right.
Absolutely.
It
It's so
is a
complicated.
combination of all the different things. And yes, we need more exercise in schools. We need better food quality globally. We
Yeah.
need to really study some of these ultra processed foods, because some of them are helpful, right? So you have like protein shakes that can be helpful for people when, they can't eat enough, or, they have certain medical conditions that require certain nutrients. But then you have the whole protein bar industry, which ranges from some that are super healthy to some that are
Yes.
basically candy bars masking as a protein.
As a health
Right.
food. I
Right. So
smiled because I have a protein bar issue. They're just, oh,
do you
yeah.
have one with you? We can look at it. We can look at the label
Oh my
together if you want
goodness.
to
I
check
have,
it
do
out.
I? No, I haven't got one with me. No, it's not in my bag. But I think
But
especially
again,
because I have a young baby who's now just
oh,
turned one,
congratulations.
actually. So not, thank you. But throughout that like breastfeeding year, I always wanted to have snacks nearby, and I got really hungry. So I thought, if I at least have something that's masquerading as a little bit healthy to quickly snack on. But
But so you bring up another actually interesting contributor. So breastfeeding actually is protective against obesity. I mean, it's
oh
another one of those things
yeah.
that, there was a study, really interesting study, that looked at the first 1,000 days of sugar exposure post conception. So
Mm,
1,000 days, that's 300 of them are in mom's belly, and the other first two are, years 1 and 2 after birth, and looked at
yes.
sugar exposure, and the sugar exposure in that 1,000 days was directly linked to type 2 diabetes risk later in childhood.
Wow.
So, like, for me, it probably was the first 300 of those 1,000 days. Like, I don't know. It's probably, maybe there's some impact in years 1 or 2 of life, but to me, it's
But you think the
much
in
more.
utero environment especially is the most important?
So even so, we just learned a few months ago that mothers who have diabetes going into pregnancy or develop gestational diabetes, their offspring have I believe, a 20% increased risk of autism and other neurodevelopmental disorders.
Yeah.
So it's all tied together, and not everything is predetermined by the metabolic health of the mom. But I mean, it makes sense, right? That's when the baby's organs are forming. So
Yes. Yeah.
if the organs are forming in a healthier environment versus a less healthy environment, the likelihood is they will form better. I don't know
Yeah.
what the right word is. Form more appropriately. Better sounds judgmental, so I'll take that
Yeah.
back.
Yeah. 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 Yeah.
They'll form the way that they were initially intended to form,
Yeah.
without the stresses of the outside world.
Yes.
So
So
that's a big,
that's,
yeah,
yeah, it's big. And I think the people listening to this most likely aren't going to be in their 20s. I think I aim this unless they're very young parents, but I aim this to be at parents. But it's interesting because some parents will be having their children will be teenagers or moving into their young 20s. So actually already thinking ahead for the next generation, for those young adults to really try to instill the healthy lifestyle habits
yeah.
there.
And again,
Yeah.
it's hard, right? If it were easy to do, we would all do it. We would
Yeah.
all get the
Yeah.
recommended amount of exercise. We would all eat super healthy. We would have salads from the farmer's market every day, and we would all, optimize. We'd all live in blue zones, and we'd all live till 112.
Yes.
It would be
Yes.
awesome
No
for
one
all
would
of us.
have a desk-based job. No one would ever
Right,
have to sit
exactly.
down for 8
We'd
hours a
all have
day.
standing desks. Right. If it were, easy,
Yes.
we would all do it.
Yeah.
So it's hard. And that's another thing that I think is really important. Well, when I talk to my patients, I try to stress how hard it is, how hard weight
Yeah.
management is, and how it's a complex chronic disease that in some people takes a lifetime of management, and I'm hoping that the paradigm will shift where people think of obesity as sort of the same as like high blood pressure or high cholesterol, where people pop a pill for their cholesterol. People take a statin. They don't even think twice about it. That,
Yeah.
the doc says, take a statin. They take it. No one even thinks twice. Or for their blood pressure, no one thinks twice. There's no stigma. There's no judgment. No
Yeah.
one. And both those diseases, by the way, hypertension and high cholesterol, are majorly impacted by food choices and
Yes.
exercise choices, right?
Yes. Yeah. Also. Yeah.
But obesity
And
gets,
stress. And I'm
and
sure obesity is also
and
influenced
sleep.
by stress and sleep.
Yes,
All those
right.
things.
All of them, right. All the chronic
Yeah.
diseases are basically come down to the same thing:
The
sleep,
food,
diet,
exercise, sleep,
exercise, stress
stress.
management. Yeah,
Yeah.
the
All
four
of it.
things, right? Those four things. You can apply that to everything.
And social
But
connection, perhaps.
I'll go with it. Social
Yes.
connection. We'll say five.
Yes.
No, I agree. I actually think that certainly helps,
Yeah.
because it helps manage stress and it helps with sleep. It probably helps directly and indirectly.
And maybe motivation to be active as well. Like
Probably,
social
actually,
connection.
right?
Yeah.
Because you go play footy in the park with your friends, maybe.
Yeah. Or nice long walks or whatever.
Yeah.
Yeah.
But I had a really good point that I
No,
was going
I'm
to
sorry.
make.
It was because all the different, like high blood pressure,
Right.
statin, cholesterol, they're
Yes.
all, yeah.
Thank you. So my point was going to be is that only obesity gets the stigma. Like if you're a 50-year-old and you're talking to your friends and you tell them that you're on a statin or a blood pressure medication, nobody says to you, "Ugh, you should
You're
have
so
exercised
lazy.
more. Yeah,
Yeah.
what's the matter with you, you toad? Why don't you get off the couch and do some, work out some more or eat better or whatever?" No one says that because they don't see it on your body habits.
Yeah.
But once they see a larger body, the stigma just immediately sets in. Oh,
Yeah.
your disease is because of your choices not to be healthier, which is totally bunk. It's not true.
Yeah. Yeah.
There might be food
Absolutely.
addicts out there, and there might be people who stress eat, and there might be people who do make poor food choices that may increase the risk of developing weight issues. But that's not the main problem. Like no one chooses. No one chooses to have high blood pressure. No one chooses to have high cholesterol, and no one chooses to have obesity. It's just not how it works.
Yeah, absolutely. Yeah,
So
it's really important, and that really we must all have compassion and
yeah,
non-judgmental,
yeah,
non-blamey,
right,
compassion that it is, a physical
yeah,
condition that
right.
no one chooses.
And
Yeah,
again, I'm not arguing that people shouldn't make healthy lifestyle choices. We all should. I try to myself every day.
yeah,
And then last night I had a pizza for dinner. Wasn't the greatest choice, But I had worked out earlier in the day, and I thought, whatever, I'm going to have a pizza.
Yeah, and that's part of living and
Right.
being, carefree, which you can be as well. I
Right.
think it's striking that balance, that you're
Right.
healthy. Most of the eight was the 80-20 rule, you can
Yeah.
enjoy yourself as well
Exactly.
and not be super
And again,
restrictive.
that's what makes life, quote unquote, worth living. The social
Yeah.
connections. Like if you're going to go to a party and they're going to serve some unhealthy food that's super tasty, yeah, have at it.
Yeah. Yeah.
But
If you want to, if you want to.
if you want to, or
Yeah.
don't,
Yeah. Yeah.
and don't. Hopefully, your friends won't judge you either way.
Yeah.
They'll just say,
Exactly.
they'll be
So,
happy with whatever.
so what do you say then to a very young child that comes into your office that's obese and that's clearly already trying to do all the things and their parents are trying all the things? How would you approach that?
So first off, not to focus on semantics, but in the U.S. especially, we're using patient first language.
Okay.
So we say, child with obesity instead of calling someone obese. And the
Okay.
reason I bring it up now is that that's one of the first things I'll do in the office is by changing the way you talk about the disease, it changes the perception of the disease, right? So if I say to a mom, your child has obesity, now it sounds like a disease. If I say your child's obese, it sounds like I'm being judgmental or pejorative or
Like an identity. Like this
like
is
an
his
identity, right?
identity. Yeah, or
Right. So
her.
in the U.S., we've moved to, it's not just with obesity. In fact, obesity was probably the last of the diseases to get the privilege of being placed after the person. So it's called, person first language. So it's person with diabetes or person with high blood pressure instead of saying, the 20 or 30-year-old diabetic came into my office. I would say a 30-year-old with diabetes came into my office.
Oh, yes.
So,
Yes.
so it is, it's a bit semantics, but it's important because the whole objective is to make the discussion of disease normalized and to take away the blame, the shame, the stigma, and the bias. So when a family comes into my office, usually sometimes the kid would actually find their way to me because they'd go on the internet and want help themselves. So they'd be sort of happy to be in my office, but often the kid is not happy to be in my office. And sometimes the family is sort of pushing it. Sometimes the kid is happy, but the parent is not happy because they don't think that they have their own biases and stigma and don't really think that their child should get care.
Wow.
So I try to, usually I'll tell a bad dad joke if I have one, because I like to use humor to sort of inject into the, like it's a heavy topic. So it doesn't need to be as heavy a topic as people make it. And so I try to make it a more of a matter of fact, almost type of experience where, you're in here for some weight issues. Okay, here's some things we can do about it. And if I do, I try to read the room. I don't always get it right, but so occasionally when you read the room wrong and you make a joke that falls flat, not the greatest. But I, sometimes when we're talking about blame and shame, depending on the parental interaction, I might say, if you're going to blame anyone, blame your parent over there because that's the person who gave you those genes that you're struggling with now. It's the hand you were dealt, and maybe it's a crap hand, but that's the one you got to play. You don't have any choice in that, right? So let's forget about how you got here, and let's go straight away into what are we going to do next? How can we make things better? And, that always starts with some behavioral changes. Like if you're drinking Coca-Cola, don't drink Coca-Cola. Minor changes. I don't tell anybody to go jump in with both feet because that's why people fail. And in general, people struggling with their weight have experienced negative interactions in the healthcare profession as well as in the real world. So I don't want to set them up for more failure. I want to set them up for success. And we just talk about, the options that are out there, the medications, the surgery, the behavioral changes, the things they need to do to start, how to get there. And I try to be sort of optimistic. I try to be positive and inject optimism into them because many of them have come from years of no success, years of dieting, years of, my mom makes me go to the gym. My dad makes me, lift weights with him, whatever it is. And then the kids don't lose weight, and they're dejected, and they're just like, they do view personal failure because their parent has told them that this will work, and then it didn't
then
work.
it doesn't.
So it must be the kid.
And children do take on stuff. They blame themselves very quickly, even very young children. And you've got to be so careful with them. If you're upset, a child will very quickly think it's something that they've done wrong. So in the same way, if something fails, they think, oh, well, I'm failing. I'm doing it wrong. Yes. Yeah.
Yeah.
So, I mean,
it's a lot of.
I'm curious,
I was
what are
gonna
some of the
say-
things that the children try that are really not working? Like their parents are trying to make them do something and it just doesn't work.
So even the most intensive behavioral programs, there's something called intensive healthy behavior and lifestyle treatment programs, IHBLTs. And I can only remember it because it's got BLT at the end. So it's kind of ironic that it's a weight management program, but whatever.
Yes.
And those are actually recommended in the United States for children with weight issues. And they require 26 face-to-face treatment hours, or maybe not face-to-face, but 26 treatment hours. And that's usually over 3 to 12 months. And those programs, so first of all, obviously 26 hours is a lot. It's, an hour every other week. And that's, with kids, it's usually a parent who also has to take that, and maybe drive 15, 20 minutes each way to the doctor's office or whatever, wherever you go. So it's a big chunk of time. Those programs result in about 5 to 7% of total body weight loss. So for those math majors out there, if you weigh 300 pounds, 7% is 21 pounds. So that's 279 after you've spent 6 months working your tail off. And so, and that's actually still recommended by lots of people. But,
and they're just like face-to-face sessions with like a
they're basically diet and exercise programs. They're basically like intensive diet and exercise programs with, but the contact hours they're supervised. So they're making sure you're actually doing what you're supposed to be doing.
And it hardly makes a difference.
Makes a difference.
Yeah.
And so not every child has done that before they come to me, but they've all tried something. Like no one, I was, my training was as a pediatric surgeon, and then I started doing bariatric surgery for kids about 20 years ago. And I was one of the first people in the United States doing that. And at the time, people thought I was nuts or mad, as I said earlier. But no one came into my office like, straight from, I don't want to say straight from the couch because, again, that sounds pejorative, but no one came straight to my office from never having tried anything.
It wasn't the first option. It was always
everyone ever woke up and said, you know what, I'm struggling with my weight. Let me see if there's a bariatric surgeon who does weight loss surgery in kids.
It's the last option. Yes.
Right, that was never the conversation.
Yeah.
So they've all tried something. And the ones who in the early days who would come to me sort of on their own or before being referred by a pediatrician or some other person were the kids of parents who had bariatric surgery. And parents who had bariatric surgery and had success, lots of them had obesity as kids. And as their kids started to grow up and they saw the same thing that they had seen in themselves and knew what going through adolescence with obesity was like for them, they would come find me and they would say, I just don't want my kid to have to go through what I went through as an adolescent. Yeah. And there's a whole process in the US and elsewhere, usually in terms of getting to surgery. So it's not like those patients still spend at least 6 months in preparation for surgery. So again, not something that we just jump to, but there'd be lots of patients I would see where they'd spend years with their pediatricians working on stuff before they got to me. And usually my first thought was, what took the pediatrician or what took you as the family so long to get to me? Because unfortunately, you could have been helped 2 years earlier, like they were, or whatever. Like there's just, again, stigma and bias in families, in the medical community, that you have to, a lot of people still think you have to sort of go sequentially, like you have to fail diet and exercise before you can move to medication or surgery. And now that there are medications for kids, you have to fail the medications before you get to surgery, which is all sort of artificial. Like there's no reason, there's no science behind that. There's certainly no reason why if if I assess your risk, your genetic risk, and I know that you have a very high likelihood of not responding to a number of different options, why would I make you go through those options before I got you to the one that was most likely to help you?
Yeah.
Right? Again, it just doesn't make, there's no other disease that we treat that way. We
Yeah.
don't make people, again, going back to the hypertension and cholesterol, we don't make people fail exercise programs or diet programs before we start them on a statin. We just give it to them. We don't care.
Yes.
Just write the prescription, send it away.
Yeah. I think one of the things might be that some people always assume if it works for me, it must work for you. And there's a lot of people that are just genetically easily thin and they're exercising and they're doing a thing and they're like, well, look at me, I'm exercising and it works. And they just assume it'll work the same for other people.
That's a great point. And I should have brought it up earlier. That's another sort of, you don't even necessarily, the people who are suggesting that you try their personal program because it worked for them, they don't mean to be stigmatizing someone, but they are. Right? And I have people, I have neighbors who know what I do for a living, who at like a cocktail party would say to me, well, it can't really be what you're talking about because I just eat right and exercise and I had a weight issue and I don't now. So why can't everybody do that? And I say, well, just like, people who eat anything they want and can't gain a pound. And then, people who eat like a bird and have weight issues. It's individual biology. And again, what is individual biology? It's genetics and epigenetics. So it is all tied together. And that's why I say it's complex. And again, I'm not arguing that people shouldn't do the healthy behaviors. We should all. But to blame folks for their disease based on a lack of interest in healthy behaviors is unfair. It's not who we should be as human beings, right? We should all embrace each other and be empathetic and sympathetic and try to come together for the common good. And,
definitely. And respect that there are just individual differences. On all levels. Yeah.
Totally. And actually, I was reading today about the UK a bit because I knew this was UK based.
Oh yeah, thank you.
And there's a obesity. Oh shoot! Now I can't remember the name of it. There's a new program that's starting in the UK. That is, where is it? It is called hold please. I got to look it up now. Obesity Pathway Innovation Program.
Oh,
so
wow.
that is a new thing that was just in August of 2025 sort of agreed upon. And I think it comes from the NHS. And it's not going to take effect until May of 2026. But it's actually moving a lot of the obesity treatment, including medications, out of the general practitioner's office and into the community. Pharmacy.
Okay, like into pharmacies. So it's over
which
the
is
counter.
Going to be it's a really interesting idea. And frankly, I'm glad I read about it because it wouldn't necessarily work in the US, I don't think, because of the different rules about what pharmacists can and can't do in Europe versus the US. But it's a really interesting, so someone understands that the scale of the disease is too large for general practitioners.
Yeah.
Right. So in the UK, I think, interestingly, the UK childhood obesity rates are about the same as the US, about 20%.
Are they? Okay. So you hit 20%, you said.
Yes. Doesn't bode well for Europe, by the way. That's not great.
That means for the future.
Right.
Yeah.
That means
we're on par.
Fast forward 10 years, you're going to be where the US is now, which is the US has a 40% adult obesity rate, I believe. England or the UK is closer to the 30-something%.
But in like 20, 30 years time, that'll be
maybe, I would say even less. I don't think I wouldn't give you guys that long, but it's all right. So the point is that in the US, that's 15 million children and about 140 million adults. I don't know the UK, the numbers. I know the percentages. I don't know
the percentage is fine.
Numbers.
Yeah.
But when you think about that number of people, so if it's 20% of children in the UK,
of 70
there are
million
no general practitioners that can handle, like if 1 in every 5 of the children they see in their office needs weight management, then their practice would be, there'd be nothing else they could pay any attention to.
Yeah. And the NHS is pretty stretched as it is. Right. So it's,
but the NHS is an interesting model in general. And I think it works well for some things and maybe not as well for others. But, and when we talk about the US healthcare system, it's completely broken. So I don't want to discuss that so much but I do think the NHS, I think this program is interesting and innovative, and maybe it'll be great, and maybe it can be scaled to other countries, or in the US or whatever. But someone is clever enough to realize that our problem is coming, and it is significant, or maybe already here and significant in the UK, and it needs a new way to think about it.
And the help needs to be accessible, and having it be in pharmacies is much more accessible than going through the kind of need to wait for an appointment and all the referrals and
Right. So I think I actually will now be following it closely, because I think it's unique. And as a scientist, obviously I care if it works or not, and I hope it works. But even if it doesn't work, then there's knowledge that's been gained because they tried something new and different. And again, if it didn't work, it means, okay, well, that's not necessarily what we need to do next, but what's the next step? What direction's next? We tried this one, didn't work. What's next?
Yes.
So I like that much better than just sort of sitting around and continuing to do the same old that we've been doing in the US that just hasn't really worked.
Clearly it doesn't work. Yeah. No. But I want to ask, so you said about 20% of children in the UK are obese at the moment.
Yep.
What can the parents of those children do to try and help their children? Because as you mentioned before, from other patients, going into adolescence with obesity is not fun for them. So what can the parents do to help?
Right. So obviously it's a tough place to be. And depending on the parents' own health and weight issues can make it easier or harder. I have the families that I think are sometimes the hardest, and it happens more often than you might think, is the families that, 3 kids, but only one has a weight issue. And the parents may or may not have a weight issue.
Yeah, which makes it even more relevant, because actually it must be genetic if those 3 children are all getting the same exposure in the family.
Right, exactly. And I actually just had a conversation with a pediatrician who is exactly that. She's normal weight or healthy weight or whatever. She has 3 kids, 4 kids, I don't know, some number of kids, but only one struggles with the weight. And actually one of the other kids said to the mom, I think my brother or sister, I can't remember, I think their metabolism's broken because he does the same thing the rest of us do and eats the same thing. And so that's sort of like the real life example of why it isn't a failure of willpower and they again, the sort of non-believers will say, oh, that child's sneaking candy bars in their room and, is going out. And again, it's just like, really, you think a 15-year-old or 14-year-old, first of all, where are they getting the money to go buy a bunch of candy bars and stash them in their room or whatever? And again, no child wants to be that way. They don't, there's no advantage. So, but the question you asked me wasn't that. The question you asked me
what the
was
parents can do to support their children.
Right. So I would say first, try to normalize the conversation again, right? And try to be as objective and non-judgmental as possible, which anyone who's had an adolescent knows that the adolescent's first reflex is to just disagree with you as a parent, just because that's what their brains are programmed to do.
Yeah.
And so it can be tough getting to them. But I think if you, again, and maybe it's easier for me because I'm the provider, but I try to make it just as science-based as possible and not opinion or
moral, not like
judgment,
character,
right?
or
Right.
yeah.
So what the parents, I mean, I'm no parenting expert. It's not, I've dealt with a lot of parents with a lot of problems with their kids. And so I think I've learned some stuff along the way. But if you ask my kids, they probably think I'm a terrible parent. Because that's just the way it is.
Yeah, it's just the way it is. Yeah.
But like if you approach your kid with, listen, I know you're struggling with this issue and I want to help you. And I don't want to be nagging you, and I don't want to be forcing you to do things that you don't want to do. But I'd like to take you to someone who could help, or discuss with you what things you think we could do to help start moving in the right direction, or something really sort of, again, empathetic and simple. Like, don't put your kid on a strict diet. Pick one thing, usually sugar sweetened beverages. Start with sugar sweetened beverages.
The low hanging fruit, the very
Right.
obvious things that
Right.
aren't clearly not contributing any nutrition.
Right. And the ones that are easily replaced, right? Like no one really needs sweet iced tea or whatever. Like you can find something that replaces that. And then work with your kid. And again, I think it helps obviously to get medical advice on this. So I would advocate for people who have access to that to use it. And the other thing that I think is really important is setting proper expectations. Like make sure your kid knows that by stopping sugar sweetened beverages, they're not going to lose a ton of weight. Their metabolic health will improve, which they won't care about because they're teenagers and could care less about their metabolic health, but it will.
Yeah.
And they'll probably feel better, which they won't notice at first, but they will eventually. And then try to build on the easy wins, right? Like, so if let's say your child is drinking 4 sugar sweetened beverages a day. I wouldn't even necessarily say to go from 4 to 0 because that can be tough, but you go from 4 to 2. And then after a week or 2 of only drinking 2, you say, great job. Let's go all the way now. Let's go to 0. And then if they get to 0, then you're like, okay, you manage sugar sweetened beverages. Awesome. Great. Let's deal with chips or, salty snacks or something else that is high calorie and not very nutritious, let's say.
Yeah.
And again, none of that, because I told you about the IHBLTs that don't make you lose a lot of weight. None of that's going to actually have them lose a lot of weight, but it will make them healthier. And it also, frankly, will help with some providers being willing to do other things like start medications or refer for surgery or something like that, because they'll see that you've already put in some of the work up front.
Yes.
Which again, to me is kind of unfair because, again, do you have to put in work before you get your blood pressure medicine or your statin for your cholesterol? No.
Yeah.
But unfortunately, many providers are still in that mindset of, well, if they don't try hard enough, can't prescribe them medication because they're not trying.
Yeah.
So leave the disease untreated because the patient's not trying. And frankly, all those changes, especially with the GLP-1 medications that are new and everywhere.
Yeah.
A lot of those changes are a lot easier after you start a medication.
Are you a fan of the GLP-1 medication?
I'm a fan of anything that can help people. And the GLP-1 medications are one tool, and they've been abused in many places. So they've gotten a bad name. And especially in the US, where there are knockoff versions that you can get from unregulated places that can have impurities or not actually have enough of the active drug in them. The access to them in the US is a big problem. So people are getting them from all sorts of different avenues, and some of them are not good. So a lot of the horror stories you hear about these medications are related to getting them, from a disreputable place.
Okay, I see.
But under proper medical supervision, they can work very well for the properly selected candidates.
Yeah.
And there are more of those medications that are coming in development over the next few years. And it's going to become like it's already sort of started the revolution, but there are different ones coming out with different mechanisms by which they work. And there are actually pill forms coming out. So it's going to be even more in the news and in everybody's face than ever. And I actually hoping someday, in a good way, because I'm hoping someday maybe you take your oral GLP-1 medication and you switch that out for your statin and your blood pressure medication and your kidney medication. Maybe you just take one pill and it's your obesity, anti-obesity pill. And then you don't have to take all those other pills. And then it'll be cheaper. So the insurance companies in the US and the NHS in England will pay for it because it's cheaper. And it'll make the disease normalized. It'll be like, oh, you're just taking the same pill that you're taking the pill that anyone would take who's, except for you're taking one pill instead of 3 or whatever. So that's sort of, again, I wish we didn't have to go there. I wish that weren't the most likely solution coming down the pipe.
But it's the world we're living in now with the kind of food system that we have and all the ultra processed foods, and it's led to this place, hasn't it?
Right. And unfortunately, there's no flipping the switch and turning back. Even if we were able to snap our fingers and go back to the food system that we had in the 1950s and 60s, the damage has been done over the last 75 years.
Epigenetically, kind of through, generations.
So even if, again, because we know that diet changes only make you lose 5 to 7% of your body weight. So it just doesn't do enough. Just changing the food system, just changing the exercise structure, playgrounds, et cetera, access, that unfortunately is not enough anymore. And we've missed that window. So now we have to throw everything at the problem.
Got to throw the heavier stuff at it. Yes.
Right. And then hopefully, again, maybe a generation, but probably, frankly, 2 generations, unfortunately. But in 2 generations, maybe then we can get rid of all the meds and focus more on the lifestyle changes, because we'll have sort of gotten through.
Because epigenetics can change in one direction, but that means it can also change back in the other direction again. But it will take a few generations.
Yeah.
Yes.
And frankly, people always talk about how obesity is sort of a new disease. And I point out that Peter Paul Rubens used to paint women who were basically had obesity, in the Renaissance period. So it's been around. It's not a new thing.
And I think all the cherubs, all the tiny, the baby, the flying baby angels, they're all.
And Buddha. I mean, Buddha was Buddha was not thin. Whether that was actually really who Buddha was or not, I don't know. But the statues of Buddha were not thin. So it's been a problem. It's been an issue. It's been part of the human condition forever.
Yeah, those genetic changes have happened in the past, but there's just more of it now, potentially because of the food system and parents giving it on to babies. Yeah. I was going to say time is running on, but I have a couple more questions for you, if you don't mind asking.
I'm happy to. I could talk about this all day, as you can already see.
Yes, I know. But actually, I now have some questions a little bit differently related. So you are clearly an expert in this field. But in this podcast, I also want to make it clear that no one's perfect. We're all living amid the mess, and we're all, we have our imperfections, and we're just doing stuff amid the chaos of life. So if you are happy to share, potentially, what is one of your imperfections? And it may be like obesity or food related, but it can also be completely unrelated.
It's related and unrelated. So it's easy for me to pick, to be honest. Like there are lots, just like there are lots of things that contribute to obesity. There are lots of things I wish I could change, especially in retrospect. But my biggest problem has always been, let's just say, playing nice in the sandbox with others. And on the positive, it's what allowed me to be a pioneer in childhood obesity treatment, because I basically said to everybody else, I don't care what you think. I'm just going to do what I want to do. And that was good. But it also is a reason why, I'm not a chairman of surgery somewhere or didn't progress up the academic ladder in the United States, because I was a pain to work with.
Yeah.
And
you were headstrong.
Headstrong is a nice way of saying it.
Yes,
a pain in the tail is probably a more accurate description. But
thank you for sharing. And this is, you are probably doing what you are meant to be doing, and you're making a difference.
I don't know.
I'm
not sure that any 56-year-old is meant to be doing social media and podcasts and YouTube channels.
Oh, yes. Gosh. Well,
I think it's
how old is Joe Rogan? He's like, he's in his like 50s, 60s, and he's
but he started it like 10
smashing
years ago. Like, I'm late to the game. I'm like, I feel like, like my children are actually, one of my children always makes fun of me because she's like, Dad, my social media is way better than yours. She's like, she'll post a TikTok about a t-shirt that she buys thrifting, and she'll get 500,000 views.
Oh my goodness.
And then I'll post, a very serious discussion about childhood obesity, and, at most I'll get 1,000 views, and she'll troll me. She'll just be like, Dad, no one wants to hear what you're talking about.
Well, she should just like tutor you. She could be your social media coach.
She does. She goes onto my she'll engage in conversations with some of the haters on the in the comments or whatever. She'll engage them just to drive my numbers up and stuff.
Oh, like that. That's nice. That's good.
But
fantastic.
She does it out of pity. She feels bad for me.
And how old is she?
21.
21. Okay, so you're at that end of parenting. Yeah, fantastic.
Is there an end? I don't think there's an end.
No, at that end, as in at that stage of parenting.
Yeah. Well,
no longer the littles and the teens, and now you're the young adult.
But I think that as far as I can tell, it goes on forever.
Yes, it really does.
Is a forever job.
It's a lifelong commitment, definitely.
Yes. That is my mess. My mess is my sort of. My obnoxious personality is my.
Thank you for sharing. No, I'm sure you're doing what you're meant to be doing. You're not meant to be the chair of something, because you've got vision. You've got a message to share. Yeah,
we hope.
But another question: does anything drive you crazy? Have you got a pet peeve about the world of medicine and language around obesity?
So again, many. Because it goes with my mess personality, but the one that's driving me the craziest right now is there's this whole thing in the U.S., and I don't know if it's made it to the U.K. as well, but this whole food is medicine movement that is very hot right now in the medical communities, and they've made a lot of headlines, and people are supporting them, and they're grabbing all kinds of attention, and it basically is gaslighting the 150 Americans with obesity that changing their diet is going to help them get to a healthy weight. It will help them get healthier. Again, I'm not saying that it won't, but there's this whole thing and it goes back to just actually the same sort of exercise gurus that have been around since the 1950s and 60s. It's the same advice. It's just packaged differently now. Food is medicine is a very catchy phrase, but food isn't medicine. Food is food. Yes. And medicine is medicine. And food nutrition doesn't need to be medicine to be helpful, right? Yeah. Nutrition is helpful. Good nutrition is helpful.
Nutrition is fuel for the body, for building blocks and fuel.
Right. Yes. So leave it at that. Why do you have to, the next one, I'm going to start talking about medicine is surgery. Why can't medicine stand on its own? Surgery stands on its own, and nutrition stands on it.
Yeah. No amount of food is going to act the same as antibiotics. So it's
exactly. And whatever chronic disease you have,
hypertension,
high cholesterol, whatever, kidney disease, yes, they are all helped by eating a better diet, but they don't supplant the medication you would take for
Yeah.
that problem. And if
Yeah.
you tried to do that, you would undertreat many, many people. So that's my
Yes.
current soapbox pet
Yeah.
peeve is that,
It's a good
like,
one.
in fact, I just posted on LinkedIn the other day for the first time, and I might add this to, like, you know, how you're supposed to hashtag a million things. But I was talking about, there was a failed food as medicine study where people were given access to food and it didn't help their diabetes control at all. And similarly, there was a program, exercise program, lifestyle program that was aimed at helping people stay in the pre-diabetes range instead of going on to diabetes. Both of these were adult studies, and they didn't work. And like there were 30% success rate for the prevention of progression of diabetes, and basically no difference in diabetes control with food access. So I coined my new hashtag, which is food is not medicine. So I'm going to start putting food is not medicine. And people are going to start hating me. People are really going to start getting angry with me.
But you're making a message. It's good. You're
Yeah,
like you're not afraid
make,
to go
yeah,
against the flow of the crowd, or how do you say it?
yeah. Well,
Swim up
come
river.
upstream, yeah. No, but in line with your podcast title, I'm not sure I'm making a message. I'm just making a mess. so,
No, 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 no.
so,
You're definitely
well, but
going
a
to
mess, sometimes the mess is good, right? Good things can come from a mess, right? That's the point.
exactly,
And that's the point
exactly.
of, I think, your podcast is to tell people, listen, we're all living in a mess.
Yeah,
And sometimes good things, you just have to, you know, pick and choose
yeah,
what can you pick and choose out of the mess that can be a positive,
definitely,
and then run with it.
definitely. Well, thank you so much. How can my listeners find you? Find out more about you? Your amazing social media channel, which you've definitely
It's not
sold to
amazing.
us,
Not,
and
it's not amazing.
LinkedIn, like all of that
It's
stuff. Have
getting
you got a
there.
website as well?
Sure. Yes. And so the website is easy. It's www.obesityexplained.com. And actually that is also my sort of handle on my YouTube channel, my Instagram, LinkedIn. All of them, I believe, are Obesity Explained. My LinkedIn might just be my name. I'm not 100% sure. And you know, people are also always welcome to just email me straight up because I don't mind that, which is Evan.Nadler at my initials, EPNMD.com. And yeah, I'm trying. I don't know that any of it's awesome yet, but maybe someday it'll be awesome. I'm
Yeah,
actually writing a book on childhood obesity, and I
fantastic.
probably
Yeah.
have to change my handle and all these things to Childhood Obesity Explained instead of Obesity Explained. But it's all
Okay.
right.
Well, that's
You
a
know.
future step. Well, when you write your book and when it gets published, come back to me, and then
Oh, I
you'll
would love
come
to,
on again and chat again, and let everyone know
because
about your book. Yeah.
I can also tell you that writing my book has been a mess. It's another mess.
Oh, I'm
It's been,
sure. Oh my goodness. Yeah, I have like a
I
vision that
mean,
in the future I want to write a book as well, and I can imagine it could be a messy creative process that
I've been
yeah.
working on it for at least 2 years now, and yeah, I understand now why people self-publish, because it's a lot easier to just write your thoughts down on something and then send it out there. And if no one buys it or cares, that's
Yeah.
fine or whatever.
And you're working with a publisher who they have a lot of
Well, I'm working with
critique, is that?
a literary agent and an editor and all those
Yeah.
things in hopes of finding a publisher. That's how it works. But
Yeah.
I spent a year with one person, and then that didn't work out. So now I'm with a different person. So it's like
Okay.
starting from scratch all over again.
Oof. Oh, but
But
keep
it's all
going.
good.
Keep going.
All the messy experiences are learning experiences, right? We just
Definitely.
we get we get information from each time we do something, and we process it and hopefully learn from it. And again, that's
Yeah,
what life experience is all about. Who wants a
definitely.
boring, straightforward life? What kind of fun
It,
would that be?
they don't exist. No, absolutely. And if someone tells you, then they're lying.
Exactly.
But
Right.
Evan, it's been so nice to chat to you. Thank you so much for bringing this important message. I think a lot of listeners will have had their perception changed after listening to you. So that's really important. And
I
hopefully
hope so.
it makes a whole bunch more very empathetic people that
Yeah,
are not judgmental.
that would be
So
the hope. But even if we just
definitely.
change one, even if there's just one, I'll settle
Yeah.
for that. One person at a time. But yeah, happy.
Perfect.
It was awesome being on, and I'd happy to come back anytime.
Oh, you're so welcome. Well, let me know when you've got the book.
Will
All
do.
right. Well, take care, Evan.
Cheers.
That was Evan Nadler, everyone. What a fascinating conversation. And I'm very curious, has this changed any preconceptions that you might have had? Or is it directly applicable to you or one of your children? I would love to know if this episode has touched your life in any way. So just get in touch, either email or Instagram or LinkedIn, whatever you like. That would be amazing. And perhaps send this episode to a friend if you think it might be relevant to them or just interesting to them. Please do. And lastly, if you like my show and you are wanting to support me, a free way that you can do this is by just leaving a little rating and review. It just takes a minute to do, and I would massively appreciate it. So thank you in advance. And for now, my little baby Daisy is waiting for me. I've been away for a little while, so I'm excited to get back to her and to my other child, who is just coming back from nursery right now. So have a lovely week, and I will get another episode to you next week. So until then, take care.